We're going to talk primarily about the physical exam of the hand because I know that Dr. Feely will be going through the shoulder. One of the things that we actually talk about first is I oftentimes see neck pathology associated with hand. So I do ask the patient usually to give me a neck range of motion, which is very simple in flexion, extension, and rotation. So I just to make sure that, if they have neck pain, I want to make sure that I've assessed that. If it's really focused down on the hand, then I will move on. But I do check to make sure that they have full elbow range of motion, shoulder range of motion, and then I move to the hand. Okay. So as we talk about it, so if I have, we're primarily looking at the hand. If I have you do a full elbow range of motion, so usually I will tell the patient to flex their elbow up and then fully extend their elbow. I usually then have them tuck the elbow in at their side, and this is where patients will cheat a lot with motion because you can get motion by just moving your arm rather than moving your elbow. And so sometimes you'll have to say, tuck your elbows in at your side, give me palm up and palm down. And sometimes people that don't have full elbow motion or have some wrist limitations, they might swing their arm across their body or out. And so sometimes you actually have to tuck them in and say palm up and palm down. And if you have trouble assessing it, you can put something like a pencil in and have them hold it so that you can see how much supination they have here and then how much pronation, right? Once that's done, I have them do the wrist extension. And the way that I do wrist extension that's easy to assess both sides is I say put your hand in the praying position, and this lets you see wrist extension of both hands at the same time and wrist flexion here, right? And then I have them look at me with their hands up like this and then give me a wave sign, right, the beauty pageant sign. That lets you check radial and ulnar deviation, and then I have them make a full fist. And that way I get a quick exam in terms of range of motion. I know that she has full grip, full wrist motion, and then I move on after that. And so when we talk about the hand exam, oftentimes this is when I say, take one finger and show me exactly where it hurts, which helps me narrow it down. But if I am assessing somebody and I'm trying to palpate where the pain is, typically I start on the forearm and I move up the forearm. And so really what you're palpating is you want to do it in a systemic way, right? You want to say, okay, I'm going to start on the radial side, and then I'm going to move dorsally over to the ulnar side, and then I'm going to come volarly, or whatever way that you do it. And you start from proximal and you move to distal. And so as I palpate here, you always say, let me know if anything is uncomfortable, but you're palpating along the radial shaft here, up to the radial styloid here. So in de Quervain's, this is where it would be tender here. And as you come more distal, you will run into that snuff box, right? And the snuff box is where somebody, if they had a scaphoid fracture, they may be tender. And if anybody has pressed over their own snuff box, it's tender. So press your other side too. So if you're ruling out a scaphoid fracture, make sure that you press both sides. And so you can see here, here's the snuff box. I think you can see that on me. That's where you press in ulnar deviation to see if somebody's tender. So I would have her ulnar deviate and press and say, is that painful? Just distal to that is the CMC joint. And so you can press on the CMC joint to see if they have tenderness there. The grind test is when you take the thumb. I'm holding her metacarpal stable here. I'm holding the wrist up here. And what I'm trying to do is jam the metacarpal in and then move it back and forth. And you can see that her CMC joint is mobile here. And you try and elicit pain if they have that. The thumb adduction extension test I was telling you is very good for CMC arthritis. All that you're doing is pushing the thumb in towards the body and then extending it up like this. And so that is painful in somebody that has CMC arthritis. So now we've moved along here. The next thing, if you're coming up the thumb, trying to look at somebody's thumb, the next, on the dorsal aspect of the hand, what you may notice is that if somebody has like a gamekeeper's thumb or a skier's thumb or some type of injury to the thumb, you want to be able to assess the thumb here. If you stabilize the thumb at the proximal phalanx and over the metacarpal, what you're doing is you're assessing for stability. And so I'm applying a varus valgus stress here. So I'm in full extension. I have my two fingers holding the metacarpal, and I'm trying to see if it opens up. And as you can see, She opens up a tiny bit, but has a solid endpoint. So it feels like I'm hitting a wall. And you can do that this way, and then you come the other way to check the radial collateral ligament. So right now I'm checking ulnar collateral ligament here. So you do that in full extension, and then you do in 30 degrees of flexion the same thing. And you want to see, you compare to the other side, and you see if they have an endpoint. So now I've basically done the dorsal aspect of the forearm and the thumb. And so coming back to the rest of the wrist here, you can palpate the radiocarpal joint here, and it's usually where you feel that nice soft spot here. Just proximal to that is right where the scapholunate ligament is. So people may be tender here if they have a ganglion cyst, if they have a scapholunate ligament injury, if they have a wrist sprain, they may be tender in this spot. An easy way, if you can't quite feel it, is just proximal. That bump on the back of the distal radius is called your Lister's tubercle. If you slide up about a centimeter distal to that, you'll fall into that same spot, right? So that's where, so we're kind of midline over the dorsal aspect. As you keep coming across the wrist, you're getting towards the ulnar side. And so you can palpate for tenderness. So if you've ever seen anybody that has a triquetral avulsion fracture, which is really just a glorified wrist sprain, they oftentimes are tender on the ulnar side, which is just distal to the ulna, which is right here, and slightly distal to be tender over here. Then as you come across, we're really now on the ulnar side of the wrist. Sure. And so now we're on the ulnar side of the wrist here. So this is where you're tender for a triquetral avulsion fracture. Over here, so I'm on the ulnar side of the wrist. This is called the fovea. So it's between the ECU, so the extensor carpi ulnaris is here, and the flexor carpi ulnaris is here. And the ulna lies right in between. And just distal to that at the level of the wrist, this is the fovea, or that soft spot. So you can see as I move her wrist back and forth, I can feel that soft spot. That's where the TFCC lies. And so that's where you can have tenderness if you have a wrist sprain or if you have a TFCC tear, which you can see in people that have like a rotational injury, maybe playing tennis, or a torque injury. They may have tenderness here. And so this is where you palpate for tenderness. And it's called the fovea sign if this is where they're tender, right? The other thing is the ECU is up here. So ECU tendinitis is relatively common. You may see pain along the ECU as you palpate. Or distally, it inserts at the base of the small finger metacarpal, so it's tender right there. Primarily, that's what you have on the back of the wrist here. Up here are the MP joints. Here are the fingers up here. Now, if we flip over to this side, so again, volar side of the wrist, what you may see, the FCR, you can get FCR tendinitis. People that have thumb CMCR arthritis may actually get an FCR tendinitis associated with that. So over the FCR, they may be tender. As it inserts, it comes up over the scaphoid here. The bump that you feel with a little bit of wrist extension here, tenderness, that's your scaphoid tubercle that you can feel right here. So you may see some tenderness there. As you come across the hand here, the next thing that you will feel on the ulnar side is your pisiform, which is the bone that you will see here. You can see it on this wrist here. And that may be tender. Again, that's where your FCU comes in and inserts. So as we move on to the hand exam on the volar side, you can clearly see the wrist creases here. Remember, this is the carpal tunnel. So it's kind of where the thenars and the hypothenars meet. So if you're looking for thenar atrophy, you're looking for atrophy along the muscle here. If you say, I'm going to check your strength, so here is the palmar abduction. So it's not in this plane, it's up here, and I say, hold your thumb there, don't let me push down. And this is what I'm doing, trying to push her hand flat into the palm there, and you can see her muscle firing here very well, right? And so that's a nice way to check for that. So if I'm assessing for carpal tunnel, this right here is where the carpal tunnel is. And so you can do your Tinel's, which is pushing right over this and saying, does this cause any pain or any discomfort? She may say, oh yeah, it reproduces tingling in my finger. The Durkin's compression test is where you press here and you just hold and you talk to the patient, and you can hold up for 60 seconds. So that would also reproduce symptoms. Or the Phelan's is a flexed position here. And again, that's 60 seconds before it's a negative test. And so that's how you're diagnosing carpal tunnel and then feeling for sensation up in the fingertips. As we move distally along here, so right where the thumb meets the palm here, and you come down from midline. This is the A1 pulley. The A1 pulley is along here for the fingers, so it's along the distal palmar crease that you see here. And this is where in trigger finger you will have tenderness to palpation. So you may feel triggering if you have them flex and extend the finger, but as I said, the diagnosis is usually it's always a trigger finger. Think about pressing here first to see if this is where they're tender, and then having them flex down against you to see if you can elicit any triggering. Same goes for the thumb. Now, as I mentioned before, when I inject for trigger finger, I actually inject at this crease here, the proximal digital crease. Although this is where the A1 pulley is, I inject here midline. I go all the way down to bone, reposition like this, have a hand here, and I inject so that I can feel the fluid going up and down the finger. The last thing that we can talk about is in the setting of ulnar nerve, right? So as I mentioned before, you take the elbow through a range of motion, you palpate. Can you see her elbow here at all? There we go. So if I'm taking the elbow through a range of motion, what you want to do first is palpate on the nerve. So I'm feeling medial epicondyle here, and I'm feeling olecranon here. And this is where the cubital tunnel is, right in between. So I would put my finger over it, take the elbow through a range of motion, and see if I feel any subluxating, right, or any dislocating nerve. And then you're pushing on it, flexing up, and then you want to say, do you get any, symptoms? Do you have any numbness in your fingers here? So that's the flexion compression test that you're doing. You can also check a Tinel's over this. When you look at the hand, as I had shown you in the picture before, I am looking at her hand here to see if there's any atrophy here and in between the digits here, right? So this is your first dorsal interossei here. And as I mentioned before, hold your fingers out in the peace sign. If I'm checking strength, it's really hard to say whether that's normal. So what I typically do is I say, relax here for 1 second, point your finger a little bit towards the floor and over towards the door there. Now hold that finger there, don't let me push it back. And you can see much better that she has a lot more strength here, and that's the last branch of the ulnar nerve as it comes all the way around. So that tells me that the ulnar nerve is working all the way around, and then I can see the muscle actually firing here. So it's a much nicer way to be able to test for it. The other way that I had mentioned before is a resisted small finger flexion. So if I say make a fist here and don't let me straighten out, right? So FDP to small finger is also ulnar nerve innervation here. So those are the two ways that I will check for ulnar nerve strength. Other things that we assessed. So on the elbow, as we discussed, the medial epicondyle, slightly anterior to that, this is where golfer's elbow or medial epicondylitis is. This is where they're tender to palpation. This is where you could do an injection if you need to do an injection. And then finally on the lateral side here, here's the olecranon. Anterior, you can feel the lateral epicondyle, and this is where you're tender with lateral epicondylitis, and you'll have pain with resisted wrist extension. You can say, hold your wrist up, don't let me push down, right? And she has good strength here, and sometimes they'll either be weak or they will have pain that reproduces their symptoms. And so if you are worried about radial tunnel, they're not tender here, they're tender about 4 finger breadths distal, which is down here. And that's where they have that general forearm ache, and they may have some finger weakness. And so that is primarily the hand exam that you will need to do, a kind of quick and dirty hand exam. And hopefully you'll be able to diagnose all your hand injuries from now on. So that's it. Thanks.